Hello viewers, I am Dr. Somnath Gorai, pediatric intensivist in Bhagirathi, Neotia, New Town. Today we are going to discuss a bit odd topic, that is diabetic ketoacidosis in children. So not like cough and cold and day-to-day respiratory problem, this is a bit uncommon but not rare. And when we say diabetic in children, always parents become concerned. It is rare, or is it possible? But yes, it is possible. And sometimes they come to our ICU in a acute complication, that is diabetic ketoacidosis. Today, along with me, we have Dr. Sayan Banerjee. Hello, Sayan.
Hi.
He is a pediatric endocrinologist, and as a team we manage this kind of patients. So diabetic ketoacidosis as well as diabetes in children is not rare. So Dr. Sain, what is the incidence and prevalence of diabetes in children?
So, sir, as you just said, for parents, it is a bit of a shock to come to know that diabetes has happened to their child. And even if we speak to the general population about diabetes in children, they find it impossible. But for our viewers, I would like to tell that India is the leading country at the moment in terms of type 1 diabetes in the pediatric population. Just to make it simple, India at the moment every year has newly diagnosed type 1 diabetes at 20,000 per year. And to make it simpler, every day in West Bengal, around 4 children are having newly diagnosed type 1 diabetes, and most of them land up in decay. So, sir, please tell us, how do these children land up in the PICU with decay?
Most of the time they presented to a general pediatrician with respiratory distress and abdominal pain, vomiting and dehydration, this kind of symptoms. When they have typical breathing pattern, that is acidotic breathing, and someone suspected that they are having, that can have diabetic ketoacidosis, they check the blood sugar and it come quite high. So they referred here to our PICU and ultimately they landed up in ICU. So usually, though the presentation is can vary, but usually they present with dehydration, weight loss, abdominal pain, and severe respiratory acidosis or acidotic breathing. So when they landed up in ICU, we start managing them with the dehydration has to be corrected early. So normal saline and bolus and IV fluid has started, and we have to monitor strictly. And after initial dehydration correction, we have to start insulin. And we all know that insulin is a important for treatment of diabetes. So, Dr. Sain, what is the importance of insulin here in diabetic ketoacidosis?
So, as everyone knows, diabetes is a deficiency of insulin. So, if you have to bring down the sugars to normal level, you have to give insulin. So, the treatment for any diabetes or a child presenting with diabetic ketoacidosis is insulin. But we have to monitor it very closely. Like, we cannot expect that the sugars, if the sugar at presentation was 600 and within an hour we bring it down to 200, it is not possible. So there are specific monitoring protocols to check the drop of insulin that is occurring every hour. So, sir, please tell us, how do we monitor these patients in PICU such that they don't land up into complications?
Yeah, so that is very important, and we cannot manage this kind of children in normal pediatric ward. They have to admit in pediatric ICU with proper backup care, and along with pediatric endocrinologists, pediatric intensivists, and proper nursing team has to be there. So we have to strictly monitor, like every hour blood sugar. Every 4 hours you have to check the serum electrolytes, so the sodium and potassium particularly, that should not hay and wear. And also you have to check the acidosis part, that is, as I told, that it present with severe acidosis or acid in the body become quite high, so that gradually that should be corrected. And as Dr. Sayan told, that the blood sugar should not be corrected rapidly, and they need to be monitored for other vitals along with some CNS manifestation, like any features of cerebral edema, because if we correct them very fast and their electrolyte imbalance is there, that can cause cerebral edema and there is neurological complication will be there. So tell us something more about diabetic ketoacidosis, and what are the other things from your side you will monitor.
So, as you said, sir, diabetic ketoacidosis, if it presents late, can develop cerebral edema. For the general population, it is a CNS complication. Apart from that, these things, sir, manages in the PICU, but we have to monitor for many other things as well. We have to check for potassium levels, because after cerebral edema, the most common complication that can occur, which can lead to death, is hypokalemia, is low potassium levels in the PICU. Along with that, as we have already discussed, as people do not think of diabetes in children, they are usually diagnosed very late, so they rarely, they may require dialysis as well. So we have strict monitoring protocols to check and intervene whenever possible. So, sir, when you manage in the PICO, what is the general time duration that is required for resolution of decay that we
So
generally see?
usually 24 to 48 hours required for resolution of the acidosis part and the correction of the blood sugar level. And once we gradually go into the resolution, we have to switch to the injectable insulin to the subcutaneous insulin. And before that, I want to mention two things, that this kind of diabetic ketoacidosis patient present with severe dehydration along with polyuria, that is urine output will be quite high, and not like other dehydration where we can see that urine output goes down and there can be severe dehydration, but here both can be present simultaneously. So as Dr. Sayan told, sometimes if urine output is less and diabetic ketoacidosis is there, that probably some renal injury is there, and we should not we have to rule out some other secondary infection is there which can precipitate diabetic ketoacidosis. So infection workup has to be done there. So once we manage the initial acidosis part and the diabetic ketoacidosis get resolution, we have to go for subcutaneous insulin. So what are the, Dr. Sain, what are the criteria for resolution of diabetic ketoacidosis, and when you start subcutaneous insulin? Just overview.
These are the things that generally sir manages and tells me when to switch over to subcutaneous insulin, but I'll tell you all. So when the child presents to us with acidosis, the resolution of acidosis is when a pH goes more than 7.3, when the bicarb goes more than 15, the anion gap closes, and the child is fit for oral intake. This is the point when we decide to switch from IV insulin to a subcutaneous insulin. So subcutaneous insulin, we generally give two types of insulin. One is just before every meal, and the other, that is long acting, that will generally be acting for around 24 hours. So generally, child with type 1 diabetes has to take a minimum of 4 injections per day. And this is what I want to tell every one of you viewing this. The ideal method for children with type 1 diabetes is this regimen of insulin, which is to be taken 4 times per day, and not an insulin regimen which is 2 times per day or any oral medications. If any child with type 1 diabetes goes in for oral medications or twice a insulin, his control will either be never achieved or will be always suboptimal, and the child will develop complications very rapidly or again land up in decay very rapidly. So go for insulin therapy which is adequate and appropriate. So, sir,
So, Dr. Sayan, so obviously parents now have overview about the diabetic ketoacidosis and diabetes. So I think they have few questions like, should you check each time we have to prick the child to check the blood sugar, or we have to give each time injectable insulin or in the subcutaneous part? So what are the newer methods? Is it there so that we can avoid this kind of pain?
so this is very important. Like the very idea of management of type 1 diabetes is based on monitoring. Now, the monitoring that was generally available throughout the course of type 1 diabetes management was via checking of the blood sugar. Now, the checking of blood sugar, which was available, and most of you might be knowing, is that from a finger prick. Now, that in type 1 diabetes is required for a minimum of 6 times, and that can become very, very painful for a child. But without monitoring, there cannot be any appropriate management, appropriate control of type 1 diabetes which can be ever achieved. So there are newer techniques that just sir mentioned, newer techniques for monitoring of blood sugars, which are generally painless. So we have CGM, that is continuous glucose monitoring, which is just the size of a less than the size of even a 1 rupee coin, and that is attached over the arm or the abdomen, and it checks the blood sugar every minute, and you can easily see how your sugars are fluctuating with every meal, every activity, every stress, and you can adequately plan and manage your type 1 diabetes accordingly. Along with that, as insulin has to be delivered, but techniques can differ. So, insulin, as you all know, is to be given via injection. Now, the injection can be given via pen on the abdomen, but the latest techniques is of insulin pump. And I want to tell all the viewers is that the first time in the life course of type 1 diabetes is that insulin pump therapy is achieving almost normal blood sugar values and normal HbA1cs as any other child or adult who doesn't have diabetes. So the future of type 1 diabetes is bright. Along with that, I would also like to tell all the viewers who think of cure in type 1 diabetes, cure still has not arrived, but control surely has arrived. So, sir, any final word on this?
So, most importantly, type 1 diabetes and diabetic ketoacidosis, though it is rare but not uncommon. So whenever there is any doubt, like abdominal pain, child is passing so much urine, there is weight loss, and along with that, respiratory distress, they need to check blood sugar, and you need to consult your pediatrician, and they need to check blood sugar in those cases. If they found that is having that is suspicion of diabetic ketoacidosis, they should be referred to a center where proper pediatric ICU care as well as pediatric endocrinological backup is there, and child needs strictly severe monitoring. And for with monitoring and our PICU care, almost all diabetic ketoacidosis child become better within 48 hours, and after that they need to uh, go to the pediatric endocrinologist. They should take over the child, and lifelong insulin is needed, though it is initially it is very shocking things that our child is having diabetes, which we have found that is usually a elderly age group disease, but can happen in child, though the type is slightly different, but that should can be managed easily, and initially they should not miss to pick up those cases. And from your side, any final word?
So, the final word is if you have diabetes, insulin is to be taken, but a pediatric endocrinologist and a pediatric specialist, endocrine specialist will guide you as to what are the nuances of giving insulin, what are the nuances to manage hyperglycemia and hypoglycemia, so that your child, even with type 1 diabetes, can live the life he wants to live. So, we hope that this discussion will benefit all the viewers who have type 1 diabetes or wish to know about type 1 diabetes and DKA. Along with that, via the podcast, I would also like all the viewers to share their views and to ask any questions that they have in the comment box. And I will surely be very happy to reply to each and every one. Thank you all.
Thank you.